Hello, I'm Dr. Julie Brahmer. I'm the director of the Upper Aerodigestive Cancer Program and professor of oncology for the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins. And I'm leading today's discussion regarding immunotherapy updates. And this will be a truly interactive showcase. And so, certainly, please send us your questions or comments through the chat so that we can discuss how our practices are changing and answer any questions that you may have regarding this. So I will get to introduce our esteemed faculty, Dr. Finn, who is a professor from UCLA. Dr. Finn, what is your particular interest in research here today?
Yeah, hi. Thank you for having me. I'm a translational researcher in doing some lab work and clinical work. My clinical work has spanned drug development, some work in breast cancer, but in the area of immunotherapy, really focused in liver cancer, hepatocellular cancer.
Well, welcome. It's great having you here today. And Dr. Warrior, who is also a assistant professor at Johns Hopkins as well. Welcome, Dr. Warrior.
Thank you very much, Dr. Brahmer. So yes, as Dr. Brahmer mentioned, I am a medical oncologist and clinical investigator at Johns Hopkins. And so I see patients a couple of days a week, and the remainder of my time is dedicated to developing and leading clinical translational trials, trying to improve outcomes for patients with high risk and advanced skin cancers.
Well, thank you so much for joining us today as well. And so we're going to hop into the different topics, and we're going to focus on melanoma, hepatocellular carcinoma, as well as non-small cell lung cancer. And we're going to start off with frontline options for metastatic disease, move to early stage disease, and talk about the new adjuvant and neoadjuvant therapies. We'll touch on adverse effects or side effects from immunotherapy and how we handle it in clinic. And then also we're going to ask each faculty to really give us what do they see as the top couple future directions, or what's the upcoming data that we want to keep an eye out for. So we're going to start with Dr. Warrior for metastatic disease and focus on melanoma first.
Sure, thank you so much. So just to level set here in terms of the landscape of melanoma, it really happens to be the case that just about 5 to 10% of patients present with stage 4 or metastatic melanoma at time of presentation. A more likely scenario is that patients may have had an earlier stage or high risk earlier stage of melanoma that then recurs and becomes metastatic. And we often see patients in that context as well. There are about 100,000 cases of melanoma newly diagnosed every year currently, and it's one of the cancers of which the incidence continues to rise. So we have a lot of work to do. But the good news for both patients and providers is that the treatment landscape has certainly dramatically changed, especially over the past decade, and we have many frontline options at our disposal. When I talk to patients, I sort of simplify this into we have 3 really big groups of therapies that we consider. Immunotherapy, targeted therapy, and then a little bit way down the list for us would be chemotherapy as well. And immunotherapy is the focus of today's discussion. And so when we think about frontline options there for a patient with a de novo presenting with metastatic disease, we're sort of thinking about balancing factors of the risk profile of therapies we have at our disposal. That includes single agent immunotherapy, anti-PD-1, combination immunotherapy that's targeting 2 different checkpoints, anti-PD-1 plus anti-LAG3 or anti-PD-1 plus anti-CTLA4. When we think about each of these different options, they each come with their own flavor of risk reward, so to speak, in terms of how likely is it that we can get the tumor, the melanoma, under control, but also, how likely are we to cause some type of side effect with these particular approaches. Certainly, as we turn up the heat by going from the single immunotherapy by itself to the combinatorial approaches, the risk of those side effects goes up as well, and I'm sure we'll dive into the adverse effect a little bit more. This really is a bit of a gray area in terms of how we choose which particular approach up front. And often it has to do with piecing together, what else is going on with the patient, what's their performance status, what are their clinical comorbidities, how aggressive is the melanoma that we're dealing with? Is it very low tumor burden, or is it widely metastatic and we're at risk of some visceral crisis, right up front? And so it's really piecing all of this together. And so I'll pause there, sort of introductory thoughts, and we can certainly dive in deeper as we go.
Well, thank you. Dr. Finn, what about for HCC, for metastatic disease or unresectable disease?
Yeah, so much has changed in the past few years, and it's appropriate melanoma goes first because in the IO space, that has paved the way. And a lot of the questions we're facing now in liver cancer, the melanoma folks have been facing for a long time. If we look back historically in liver cancer, for decades, sorafenib, a TKI, was the only thing we had. In 2017, lenvatinib, another VEGF-targeted TKI, was approved based on non-inferiority to sorafenib. And it wasn't because of lack of trying. We never had anything that really improved survival versus sorafenib. And in second line, multiple TKIs have been approved as well. And most of them do not have significant objective response rates. And we've been telling patients, we're going to help you live longer by slowing progression. Lenvatinib did have a higher response rate, around 18% now repeatedly, but the big moving of the needle came in 2020 with the approval of atezolizumab and bevacizumab, right? And this is unique, I think, in cancer medicine, that we have a VEGF antibody and a PD-L1 targeted agent approved without chemotherapy. And this breakthrough really established for the first time a regimen that improved survival versus a TKI, and it was associated with a fairly high response rate, an objective response rate of 30%. And those patients who respond, these responses are very durable. And the IMbrave 150 study really included a fair number of high-risk patients. Before this, we had seen a setback because single-agent nivolumab versus sorafenib failed. And Nivo had accelerated approval based on Checkmate 040, which showed a nice response rate, 15%. But at the end of the day, that could not beat sorafenib, which led to these combinations. And as we sit here today, we have several combinations that have read out with positive studies and approved or soon to be approved. And I look at these as IO VEGF, being bevacizumab and atezolizumab. Then we have IO. We have Nivo Ipi, which read out at ASCO and has accelerated approval in the second line. But based on Checkmate 9DW, we expect that to be approved in the frontline setting. And that study versus TKI met its endpoint of improving survival. Unlike the VEGF combination, did not improve PFS, but had a very high response rate, an objective response rate of 36%, which in liver cancer, I almost feel like a lymphoma doctor now with the regimens we have, because we see durable responses. And before Ipi-Nivo read out, we saw the readout from the Himalaya study, which was a single dose of tremelimumab, CTLA-4 inhibitor, in combination with durvalumab. And this study also improved survival versus sorafenib and had an objective response rate of 20%. Interestingly, the IO regimens don't lead to improvements in PFS, but do improve OS, and we have very durable survival with those. Several of these studies have long follow-up, and we are seeing around 20% survival with durva-tremi at 5 years. That's remarkable in this group of patients. And then we've seen data with TKIs and IO in combination. Lenvatinib and pembrolizumab did not meet its endpoint in frontline advance, but we'll talk about its use in earlier stage disease. And also we saw another phase 3 study, which has not led yet to approval in the United States, but the CARES 301 study was rivasirnib or apatinib, a very potent VEGF multikinase inhibitor in combination with pembrolizumab, PD-1 antibody. And again, very durable responses, high objective response rate. And that was in the 26% range, and improved survival. So in frontline, currently I have two approved regimens, atezobev and durvalumab. Presumably ipi-nivo will be approved in frontline setting, and maybe the TKI regimen. And well beyond the scope of this discussion, it's how we will choose and the way to sequence things. But a very exciting time for us in IO space and liver cancer.
Wow. That's all I can say. The life is certainly changing for these two diseases, and certainly significantly different compared to when I finished my fellowship. So for non-small cell lung cancer, we're sort of now at a lull. We've had great advances for metastatic non-small cell lung cancer, and we're now just hoping to see further advances. So for non-small cell metastatic, what we decide to start therapies with really depends on whether or not a patient has a mutation. So we look for mutations that targeted therapy may be better for, and immunotherapy doesn't work quite as well for. And so for those patients, it's really targeted therapy. For patients without targetable mutations or then we look at PD-L1 status, and we use that to decide whether or not, if patients' tumors are PD-L1 high, single agent immunotherapy is kind of the mainstay. We have pembrolizumab, cemiplimab, as well as atezolizumab approved for use. Or for those patients who have PD-L1 intermediate or a high burden of disease, we use chemotherapy plus immunotherapy, and the mainstay of treatment there has been pembrolizumab plus chemotherapy, and chemotherapy really depends on histology. And then for patients with PD-L1 negative disease, we certainly can use chemotherapy and immunotherapy together, but that's where I think the benefit of IO-IO combinations really come in. We have a Checkmate 227 regimen that is only approved for PD-L1 positive. That's with nivolumab and ipilimumab, but does have NCCN compendia listing for PD-L1 negative tumors, where in that, with using that regimen, the nice thing about that regimen, it has no chemotherapy and really did do better compared to chemotherapy or IO plus chemotherapy in patients with PD-L1 negative disease, but was not designed to answer that question. Now, we also have other IO plus chemotherapy regimens. One is based on the Checkmate 9LA study that gave nivolumab and ipilimumab and gave 2 cycles of chemotherapy, and that was it. And again, across the board, it did do, that regimen did improve survival compared to chemotherapy, but really where we saw the action was in PD-L1 negative disease compared to chemotherapy, much more compared to what we would have thought, and particularly for those patients with squamous cell histology. Then we also have the durvalumab and tremelimumab. You can see this theme with HCC as well. We have the Poseidon trial that showed improvement in survival when patients received durvalumab plus tremelimumab, as well as combination chemotherapy. For 4 cycles, the chemotherapy was given, and the tremelimumab delivery was stopped, was only given an additional time after the chemotherapy completed. Interestingly, in this trial, we saw improvement in survival across the board, but particularly interesting in particular subsets. In non-small cell lung cancer, the subset of STK11 or KEAP1 mutations, these patients tend to do worse with immunotherapy. But in the IO-IO combination, particularly in the Poseidon trial, it seemed that those patients with those mutations did quite well compared to what we would have expected. So again, I tend to move towards the IO-IO combinations for these particular patients with these mutations that are less likely to respond to immunotherapy. So certainly life is changing in non-small cell lung cancer as well. But we're hoping, and we'll talk about this a little bit next, is to move all of this into the early stage setting. So, Dr. Finn, for early stage or resectable HCC disease, where are we at with immunotherapy?
Yeah. So we'll try to be brief because we have a lot to talk about in a little time. Patients who get resected are at high risk for recurrence across the board with liver cancer because they have a diseased organ. And there's been efforts to decrease that risk of recurrence. Initially with sorafenib, which failed. But now that we have modern drugs that are very active, there's several ongoing phase 3 studies looking at, again, single agent IO, Nivo and Pembro have studies ongoing, as well as combinations. And the first and only of these phase 3 studies yet to read out is the Embrave 050 study, which was presented at AACR in 2023 and updated ESMO a few weeks ago. And this study was stopped at its first interim analysis because it showed that in patients who are felt to be even higher risk for recurrence based on tumor characteristics, that a year of atezo-bev decreased the risk of recurrence. It improved recurrence-free survival significantly versus standard of care, which was just observation or supportive care. However, that interim analysis was done only at 17 months of follow-up. And at ESMO this year, with longer follow-up, those recurrence-free survival curves came back together, which took what looked like a positive study and made it negative. This won't get regulatory approval, but there is a signal that there's probably some patients who do get a benefit. We just don't have a way of identifying them. We have no biomarker, and the clinical characteristics, did not support a specific group. The other early stage group of patients are those who are intermediate but not resectable. Patients who have liver confined disease, which have typically been receiving local regional treatments, chemoembolization, the backbone for this population. And now there's several ongoing and completed studies looking at leveraging medical treatments, IO based, on top of local regional treatments. And 2 of these have read out but have not led to approval. The first being Emerald 1, which looked at durvalumab and bevacizumab in patients who got chemoembolization and showed a significant improvement in PFS, progression-free survival, but we have not seen any overall survival data yet. And then at ESMO 2024, we saw the LEAP-012 study, which was lenvatinib and pembrolizumab, TKI and IO, in combination with TACE. And this also improved PFS. And they did show data showing that there was a trend towards improvement in overall survival ratio. The hazard ratio was 0.8, but not yet statistically significant. And that will take longer follow-up. So signals that we are making progress. We still need to see regulatory approvals here and a little more clarity on the data. Unlike other diseases, PFS is not validated to be associated with an improvement in OF. It's in intermediate liver cancer. And there's ongoing studies as well, but huge opportunities here, and also a big opportunity for biomarker development in the adjuvant or neoadjuvant space. And I think that is a good leeway to the melanoma folks because they have really led the way for this. And again, liver cancer is looking to copy some of these ideas.
Dr.
Yeah, thank you so much for that excellent segue. So this is certainly an area of huge interest and activity in the melanoma space. And I'll just touch on very briefly in the prior section, there were a lot of comments made about durability. Regardless of what setting we're treating our patients in, that is the name of the game, is can we not only generate a response, but can we make it long lasting? And I'll just touch on, a few studies were mentioned in the melanoma space, as alluded to. We have longer experience than most in terms of using some of these immune checkpoint inhibitors. And the Checkmate 067 study, which tested Ipi-Nivo, just had its final 10-year readout. And the point I'll make, many points to make about this, but among patients who were treated with Ipi-Nivo who were alive and progression-free at 3 years, the 10-year melanoma-specific survival rate is 96%. So that exemplifies, how durable these responses can be in some of these patients. Now let's adapt that to the adjuvant and neoadjuvant space. When we think about what constitutes high-risk melanoma, what we're really thinking about are the stage 2Bs, 2Cs, and above. And in fact, the 2Bs refer to patients that have a little bit thicker, meaning a melanoma that burrowed a little bit deeper to at least intermediate thickness, that are node negative, in contrast to the stage 3s, like in many other cancers, where lymph nodes may be positive. It turns out that because the depth of invasion is such a prognostic indicator, those that have the high risk stage 2B and 2C disease have similar melanoma specific 5-year and 10-year survival than even the early stage 3s. In fact, the stage 3As have a better prognosis. These are thin melanomas with small amount of node positivity, have a better prognosis than stage 2Bs and 2Cs in long term. So that really tells you that that depth of invasion is the primary prognostic factor. We've been using adjuvant therapy in the stage 3 space for some time now, but the news I'll highlight here that that certainly is changing how we approach our patients with high-risk stage 2 disease is there were 2 trials that were recently done, the Keynote 716 trial looking at adjuvant pembrolizumab for resected high-risk stage 2 melanoma, and the Checkmate 76K trial looking at a similar paradigm for adjuvant nivolumab in resected stage 2B and 2C melanoma. Both of these are demonstrating, with a couple of years of follow-up, improvement in recurrence-free survival and distant metastasis-free survival. We have not yet seen an overall survival benefit. Granted, it often takes many, many years of follow-up to start to see a signal in that direction. But this is certainly a conversation that we're having, and I think one of the most nuanced conversations that we have with patients, with this high-risk stage 2 setting. In the neoadjuvant space, we could spend a whole hour plus talking about this, but certainly this has been the paradigm change. At ASCO this year, the NADINA study was, of course, one of the plenary presentations. And what we're really looking at here is if we're seeing this benefit in the adjuvant space, if we give our immune system a bigger target up front, can we give it a better way to recognize what it's supposed to be fighting against, generate a more potent T cell response and a more diverse T cell response against the tumor? 2 main trials, an ADINA trial, as I mentioned, looking at flipped dose ipi-nivo in this context, given just 2 doses neoadjuvantly, followed by going to surgery, and the SWOG 1801 trial, which looked at giving 3 doses of pembrolizumab up front and the remainder adjuvantly after, compared to giving the full regimen after. Both have shown a dramatic improvement in event-free survival for patients with resectable high-risk melanoma.
Well, thank you. Well, we'll move on briefly to non-small cell lung cancer too. And I agree, we could talk about just the adjuvant and neoadjuvant all day. In non-small cell lung cancer, for those patients, again, without driver mutations, the IMPAIR-010 is approved for use in the adjuvant setting, giving atezolizumab for those patients with PD-L1 positive disease. And then we have the Keynote 091 study that is pembrolizumab in the adjuvant setting for 1 year that can be given regardless of PD-L1 status. But then over the past 2 years, we've had an explosion of neoadjuvant or now perioperative studies that have borne out improvement in event-free survival. We first had Checkmate 816 that showed 3 cycles of nivolumab and chemotherapy in patients with stage 1B through 3A non-small cell lung cancer without EGFR or ALK abnormalities, did show improvements in event-free survival. We have yet to see overall survival, but certainly for those patients who have a complete pathologic response, they do extremely well. But now in 2024, we've had over 3 regimens approved in the periop setting. And each of these trials have taken patients with stage 2 through 3B and received 4 cycles of IO plus chemotherapy, followed after surgery for a year of immunotherapy. So both durvalumab in the Aegean trial showed improvement in event-free survival. Then the Keynote 671 trial for pembrolizumab showed improvements. And then most recently, the Checkmate 77T study with nivolumab also showed improvement and decrease in recurrence when you use this type of regimen in the periop setting. So just wanted to briefly touch about, each of these regimens that we're talking about have potential side effects. And for each of your diseases that you take care of these patients who have either HCC or melanoma, even non-small cell lung cancer, what are some of the the key side effects that you're having to manage that might be special for your particular patient population. Dr. Fine or Dr.
Yeah,
Finn, sorry.
and just to remind people, you can always ask questions in the chat as we have a few minutes left. So all of us see the same side effects, itis, right? Any itis can happen, and generally they're managed the same, but certainly in the liver cancer population, we need to be cognizant of underlying liver function, right? Because a lot of our patients start with a transaminitis. They start with an elevated bilirubin. And having to figure out if these are going up, is this tumor progression? Is this worsening of their liver disease? Or is it an immune-mediated adverse event? And we just need to be cognizant that immune adverse event can happen. In the past, we only concentrated on the other issues. So getting a hepatologist involved early, seeing these patients frequently, holding treatment if we are concerned about toxicity from IO, certainly using IO regimens, the incidence of immune-related adverse events is about twice as high as with single agent IO or IO VEGF. And with the VEGF component, we need to worry about bleeding events. So a very complicated discussion, but don't be afraid to use these drugs. These drugs are changing the natural history of our patients, and serious adverse events are still pretty uncommon.
Yeah, this is such an important topic and something else that we could spend an entire lecture on. But I think there's a few key takeaways. I think one, being transparent with our patients about the potential for some of these events to be life-altering or even life-threatening is really key. And even though that may be rare on occasion, we certainly see enough patients where we unfortunately do see some of those very serious side effects. Dr. Finn alluded to the point that not all therapies are created the same in terms of the likelihood of having some of these adverse events. And with immunotherapy, I mentioned there are sort of three primary regimens that we use: single agent anti-PD-1, where we think about a grade 3 to 4 side effect risk of 10 to 20% range. With anti-PD-1 plus anti-LAG3, perhaps that goes up to about 20 to 30%, just about 10% more. But with anti-PD-1 plus anti-CTLA4, the number is close to 60%. Now, again, the likelihood of those really life-altering toxicities is on the lower end, but the fact is a lot of our patients are going to run into some of these side effects. And then as there's been increasing awareness of the side effects among other specialties beyond oncology, I think multidisciplinary care is critical in managing some of these side effects optimally.
How about, certainly for non-small cell lung cancer, we see a lot of pneumonitis. Maybe it seems like a lot more. And so certainly in a patient with lung cancer, we definitely have developed algorithms to help care for these patients and really to try to tease out. But as science changes and we start adding even more therapies, for future directions, not just for adverse events, but for future directions for each of your diseases, where do you see the field going? And we can kind of use the last few minutes.
So I'll lead off because in reality, people ask this question. I say, well, the melanoma people haven't figured it out. So how are we going to figure it out? Because they've had it a lot longer. And what I think we need to figure out is, what do we do at IO progression, right? We have a lot of drugs available. We sequence them, but nothing is really geared towards reversing IO resistance. There's those patients who get a long disease control and then progress, and those that have direct, no response, de novo resistance. And we need to figure that out. We are waiting in the frontline setting. The bar is very high now with IO doublets. Survival is probably about 2 years for advanced liver cancer. And we are very excited to see the results of IMbrave 151, which is atezobev plus tiragolumab, an anti-TIGIT antibody, versus atezobev alone. Again, the bar is very high, but early clinical data is exciting.
Awesome. Dr. Warrior.
Yeah, I'll make a few high-level comments here. So I'll say that a lot of exciting things are happening in the melanoma space in relation to what types of therapies are administered, how they're administered, and how we're going to select which therapies are administered. So to touch on briefly on each of those, In terms of the types of therapies, the one thing that's been recently approved just earlier this year is, of course, TIL therapy, tumor infiltrating lymphocyte therapy. So this is, I think, the one of the first forays into personalizing immunotherapy, and this is a process by which there's some selection of the immune cells that are trying to be active against the tumor. Those are surgically isolated and then separated in a lab. That population expanded out into a few billion cells that are then infused back into the patient with success in this immunotherapy refractory and targeted therapy refractory space. In fact, it's currently has accelerated approval for patients who have already progressed on immunotherapy and a BRAF plus MEK inhibitor therapy if they were a candidate to receive that as well. In terms of the type of administration, there's encouraging data to suggest in other cancer types that perhaps subcutaneous administration may be non-inferior to IV administration of these agents as well. And there's certainly trials ongoing, such as Relativity 127 in the melanoma space, looking at randomization of this approach. And that could certainly have a lot of impact from a financial perspective, time toxicity perspective, resources perspective as well. And then finally, I'll just say biomarker development is going to be critical. I think the holy grail is really, even in the upfront setting or in the PD-1 refractory setting, we got to get to a stage where we can look at a patient, look at their tumor, and figure out, based on these biomarkers, we should offer them X type of therapy, whether that's single agent, combination. How can we maximize the efficacy of these approaches while minimizing the risk that we're putting our patients in?
For sure.
Well, thank you so much. So for non-small cell lung cancer, we're adding on back to HCC, adding bispecifics with VEGF. So we hope to see that soon. So I just want to thank our faculty for coming on today and giving us a great insight, both in HCC and melanoma, as well as non-small cell lung cancer. And I hope that everyone found this very useful as I did. Thank you so much.
Thank you. Have a good day.
Thank you.